Thank you, sir. Allergy is, as such, is a very significant it's a public problem, and also like 1/3 of these patients can be affected by ocular symptoms, and these symptoms can be quite severe to intervene the daily day-to-day life activities in almost in 70% of these patients. And we all know, like generally, every time whenever we talk about allergy, we say like type 1 IgE mediated immune mechanism, as well as the type 4 cell mediated delayed hypersensitivity reaction. These two are the basis for many of the allergic reactions. But most of the disease, these two interplay also, like then we have to understand the pathology before treating these patients. So seasonal and perennial allergy, traditionally we think it's only due to the IgE mediated, but then again we have to understand the pathology a little bit more. This allergic conjunctivitis most of the time will be associated with the rhinitis, so it's called rhinoconjunctivitis. And in the hallmark sign will be the chemosis of the conjunctiva. Hallmark symptom will be itching. Unless the patient have itching, it is not an allergic disease. But in the initial period, this reaction will be due to the mast cell degranulation. But later, once it goes to the chronic stage, the inflammatory part of the inflammatory arm also comes into play. So once this later stages, with each time exposure to allergen, the reaction will be more aggressive and a chronic inflammatory phase sets in. So then it's very difficult to differentiate these allergic diseases from chronic recurrent inflammatory conditions, many of the ocular surface inflammatory conditions. And there only the itching is the main hallmark symptom which we have to elicit to know that this basically it's an allergy. And the management also we have to keep it in mind. Of course, the management will be before preventing the mast cell degranulation, which is the first step in this condition. And once it is released, then the symptoms has to be dealt with agents which can nullify the effects of the chemical mediators. So mast cell stabilizers still they play a long role in prophylaxis of these patients. Even our general physician colleagues, they are using it in many of the general allergies. And the time-tested ones are sodium chromoglycate, which is available as topical also. Ketotifen is available as systemic, which is often used for general conditions. But we have to remember this is mainly for prophylaxis. So once the symptoms started, if you start these medications, they are not going to give any relief to the patient, which will again deter the patient to use these agents for a longer time, which is needed in these agents. So you have to clearly, you have to start these medications several weeks before in case of seasonal allergies, or in case of perennial allergies, maybe we have to continue them for a longer time till the environment changes and the patient is relieved of the symptoms. So, and the recent ones like olapatidine, epinastine, they have a little bit of antihistamine activity also. So they are better preferred than the simple sodium chromoglycate nowadays. But again, only in the initial phase of the disease, their antihistaminic activity will be effective. And the newer antihistamines, some of them are being proposed. They have less anti-muscarinic activity, but we have to wait and see their effect, how useful they will be. And what about the topical antihistamine and vasoconstrictors? Because once the chemicals are released, we want to nullify their effect. So logically, they should be of use on this stage. But actually, in practice, these agents their effects are very transient. Not only transient, this will be followed by rebound effects. And many of them can cause allergic reactions and toxic reactions on the ocular surface, like conjunctivitis medicamentous or follicular reaction, contact dermatitis. So actually these agents can aggravate the disease. So it's better to avoid them. And the same thing holds good for even the lubricating agents. The main role in lubricating agents is only to dilute the allergens or the chemicals released afterwards. But what is the point in giving once the inflammatory disease sets in? For a prolonged use, again, it's better to avoid any agent with any preservative or the stabilizing agents for long-term use. So here we have to go for anti-inflammatory drugs. So NSAID, that's why were introduced some time back, and still their role is a little weak, only in very established allergic reactions, and we have to go for steroids. But here, remember, we are dealing with the first type 1 reaction, inflammatory phase of the type 1 reaction, so we can use steroid in the anti-inflammatory dosage, And during the acute phase, we can use steroid and taper them fast as a pulse therapy, and then rest of the time try to maintain them in the prophylactic dose of prophylaxis medications. But the vernal keratoconjunctivitis and atopic are entirely different monsters. Here we have to remember not only the type 4 reaction, the cytotoxic effect of the T cells on limbal stem cells we have to tackle with, and there will be fibrovascular proliferative part of the disease which presents as giant papillae and later scarring. And not only that, in atopic individuals, they are prone for chronic infections like viral or fungal infections. So we have to handle all these things in these patients. So here our approach will be entirely different. It is an immune-mediated disease. So we have to go for an immune modulator agents. Even steroid has to be used in the immune modulator as immune modulator. So in the active stage, we have to go for higher steroids. Dexamethasone is preferable, any clear steroid, than the suspensions, and give it as a large dose, and then you can see a dramatic response immediately, then taper it fast. But then we have to go for maintenance in most of these patients. So this differentiation we should remember. Not that steroids should be avoided in all allergies as a long-term thing. In many of these patients, they will need steroid for in long-term basis, and here we can go for lower potent steroids, and titrating the dosage and the protocol to taper the dosage it should be done on individual basis. So you can see in some patients even tapering from 2 times to 1 time can immediately flare up the reaction. So we have to titrate it individually. So it needs a long-term commitment on the patient or the parent side also with a single physician for a long time. So that has to be clearly explained to the patient or parent for a long-term follow-up. This is the most important thing in managing these patients. And the papillary reaction, severe papillary reaction, will not respond even for topical steroids. Sometimes we may have to go for supratarsal injections. Again, we have to, before going for depot therapy, usually I go for decadron injection, wait for a few weeks to make sure that the IOP rise is not that much, and then only I go for depot therapy with tricot. And sometimes we can go for even surgical excision of these papillae with AMG. These things are proposed nowadays, but they are, unless the basic disease is controlled, they all will give temporary measures only. And shield ulcer, again, we need surgical intervention most of the time. Surgical debridement or with PTK, with or without AMG may be needed to reduce the scarring. So what is inconsistent cases? What do we mean by that? Most of these cases need steroid for a long time basis. So we, instead of using steroid, naturally we have to go for other immune modulators. Cyclosporin and tacrolimus are the two we have in hand. Tacrolimus is 10 times potent than the cyclosporin comparatively. So it's more effective in my experience. It's more effective in papillary reactions. But we have to remember this. It can cause severe local immune depression. So many of these children can come back with multiple sty when treating with tacrolimus. That we have to keep in mind, and especially if we are using it in atopic individuals who are prone for infections. And also long-term safety of these drugs are still questionable. So giving them in long-term basis without proper monitoring we have to be very careful. And preservative-free steroid, because sometimes some patients will come with a list of 4 or 5 medications already with still severe PEE. As the previous speaker mentioned, this is not simply allergy. This is an ocular surface inflammatory reaction. So here we have to stop all the medications, go for preservative-free steroid, which we can constitute from injectable dexamethasone. You can see a good relief. Then once the ocular surface fully recovers, we can again slowly introduce the readily available medications. And there is no point in treating all patients with a cocktail of 1 sodium chromoglycate, 1 steroid, 1 cyclosporin or tacrolimus, 1 lubricating agent, and 1 antihistamine. And there is no role for all these agents in a single patient. That we have to keep in mind. And finally, one word about the allergies caused by our ocular medications like aminoglycosides or some of the antibiotics or anti-glaucoma medications or cycloplegics, again 2 types of reactions can be there. If it is only confined to the conjunctiva, we can simply stop the medication and it will recover. But if it goes for a periocular leathery eczematous skin reaction, then it needs systemic steroid, otherwise it will lead on to permanent scarring and pigmentation. So the allergic management in this allergic conjunctivitis, it's really a disheartening condition for the patient as well as parents, and it needs understanding of the pathology by the physician and proper teaching of this to the patient and a parent, and a long-term partnership should be there to manage these patients. Thank you.